Greetings, everyone. Welcome to Practical Talks for Family Docs, the College of Family Physicians of Canada's live clinical webinar series. My name is Samantha Moe, and I'm a clinical evidence expert with the College of Family Physicians of Canada. I'd like to start by reading the Statement of Acknowledgement of Traditional Land. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The CFPC recognizes that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The CFPC respects that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all attendees to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. Today, we're going to be hosting a pick and learn game, a game with the Jeopardy-style format where we ask you, our audience members, to choose the chronic pain topics you would like to learn about today. I have two co-presenters with me who I would like to invite to say hello, to introduce themselves and share their conflicts of interest. Mike, would you like to start us off?
Sure. So my conflicts of interest are that I work for the College of Family Physicians of Canada. Until last year, I also worked a little bit with the University of Alberta. I'm still a professor there, but I'm an adjunct now. I receive, and then of course, a little bit of clinical income. I received honorarium and research and speaking fees, that kind of thing, from a variety of sources, but never from industry. And I'm also involved in 2 clinical trials, BedMed and InRange. InRange is done, but within the last 2 years, and BedMed is still ongoing. Again, all publicly funded. Great,
thanks, Mike. And Joey, over to you.
Yeah, I'm also an employee of the College of Family Physicians of Canada, full-time. And then I also do some casual community pharmacy work at Costco still, just to keep up clinical practice. And that's it.
Great, and I'm also an employee of the College of Family Physicians of Canada, and I don't have any further conflicts of interest to declare. So I'm just going to review a few housekeeping things before we get started. Our audience today is joining our webinar from either Facebook or YouTube. In both YouTube and Facebook, you can send us your questions and we will address them at the end of the webinar or as we go along. If you are a YouTube user, please submit your questions in the chat window by logging into your Google or YouTube account. And if you cannot see the chat window, you may be in full screen mode. For Facebook users, you must be logged into your Facebook account to submit questions into the chat window. If you're watching this as a live webcast, it is eligible for 1 Mainpro Plus credit. And in order to claim your credit, you will need to complete a short registration survey. That link to the survey will be posted by our team into the chat towards the end of the webinar. Okay, so I'm going to turn it over to Joey to get us started.
Yeah, so we'll just start with the learning objectives. So hopefully by the end of this activity, we're going to be talking about a bunch of different pain treatments and what proportion of patients respond to those treatments, talking about the evidence that supports pharmacological and also non-pharmacological treatments in chronic pain, the ones that affect primary care specifically, and then just hopefully you get some takeaway messages that you can just take to practice. And if you're in clinic today, just take them forward later this afternoon. We're hoping this is useful. And that's definitely our goal. And yeah, next slide, Sam. I think sometimes when we talk about chronic pain and trying to treat it, it's just such a maze, right? One group says one thing, and you're maybe doing or using the treatments recommended there, and a year later it changes, and there's this new treatment, and everyone's using it. You're thinking, oh, should I also be using it? And it becomes really complicated because chronic pain, we say it so definitively, but it's gray in itself, right? There's so many conditions that fall into this condition, and what it means can mean different things to different people. So a couple of things to kind of note, specifically with chronic pain, this topic, or this talk, we're going to be talking about osteoarthritis pain, specifically knee and hip. It's where the evidence we found lied. In terms of chronic low back pain, we're talking about radicular and non-radicular chronic low back pain. And then in terms of neuropathic pain, post-traumatic neuralgia and diabetic neuropathy are the main specific ones we're going to be highlighting today. And just to kind of give context to what we've looked through, we've done 3 systematic reviews on these 3 topics. Chronic low back pain is going to be published in January, and we're hoping to have neuropathic pain published sometime next year. But throughout these 3 systematic reviews, we've combed through 63,000 RCT titles and abstracts, read at least 1,400 RCTs in full, and extracted close to 300 of these RCTs just to get all this data. And it kind of shows it's why this topic is so tricky, just because there's so much out there, and it's just really hard to sift through. The goal, hopefully, is late next year, we're hoping to release a peer chronic pain guideline that will hopefully make things easier in terms of making decisions for your patients and helping you out in practice. A couple of other things, just to give context to how we're going to be speaking to these outcomes. Continuous outcomes are a thing we probably commonly think about when we talk about pain. So that's something we consider like a scale of 0 to 10, rate how severe your pain is on the scale. The difficulty of looking at just this evidence is that it's hard to summarize all these different findings, because one study might use a scale 1 to 10, another one might use 1 to 20, and you have another study here looking at 1 to 50, or you have all these different scales you could use. So it's not as meaningful, or really hard to apply to practice when we look at these outcomes. So what we're going to be focusing on is something called dichotomous or responder outcomes. And that's just an outcome that it gives you an option of saying yes or no, whether you had the outcome or whether you didn't have the outcome. And for us, it's going to be a lot of the times a meaningful pain improvement. And a meaningful pain improvement, kind of dialing it down and just focusing on that, it just allows us to say, does this, how well does this, or how many patients will expect a meaningful pain improvement with these treatments. And the next slide there, Sam. So kind of mentioning there, we've focused on meaningful pain improvements. Most of the time when I say that, what it means is it's a 30% or greater decrease in pain. Oftentimes that's generally what we found with the evidence we've looked at. And it can also refer to achieving a certain threshold on a scale. So for example, if patients start at a 6, a 30% decrease in pain would those patients reaching a 4 by the end of the trial there. So we kind of equated all that to a meaningful pain improvement just to make things easier to digest and apply. And it's time to pick our topic.
Okay, and we've sent out some surveys, so we have some that are ranked right from the beginning, and we're going to go with those 3 to start with. But we wanted to give you a chance to look at this first, because you can also put in the comment sections which one you'd like us to address. And so after we've done the first few that came out by survey, we'll be going through the ones you pick and indicate in the chat windows. Okay, what's first?
So one popular one that came up in our survey was cannabis. So I'm going to turn it to you, Mike, to start with cannabis for neuropathic pain.
Great. Yeah, this came from our 2018 guideline primarily. And so Joey was mentioning, this is a good one to start with, actually, because Joey was mentioning the scales, and then we're going to talk about how many actually respond. But to give you a concept of scales, so what is it looking like for patients who started many of these studies? And it varied, of course. Some were started with a higher pain level and some started with lower. But the average is somewhere around 6. And that's standard in a lot of pain studies. The average is somewhere around 6 to start with. So that's your red baseline score. When you use placebo, in this case, it was either smoke placebo or placebo pills or oral sprays, if it was an abixamol, that kind of thing. And you can see where that took you down probably just over 1 point or so coming down on the placebo. And then using some type of cannabinoid, and that could be inhaled cannabis, it could be nabiximols, it could be nabilone, it could be anything. And you can see that took it down a little bit more. So those changes, probably when you look at them, the reason we're showing you this is we want to show you what it really looks like, and how for a lot of patients, they're not getting a dramatic improvement with any of these interventions. And the green line for cannabinoid might change slightly with other types of interventions, but it's not, most patients are getting to 2 or 1 with whatever their intervention is. Okay, Sam, next slide. Or click through. So if we look at the meaningful improvement in pain, which is what Joey mentioned, you can see that there's a couple different types. Neuropathic pain was done in one systematic review. Palliative care pain was done in another. And you can see the changes there. It's interesting, you'll see here that in many cases, neuropathic pain has a lower placebo response than what we see with back pain and OA pain. And then palliative has one of the lowest, or cancer-related pain has one of the lowest placebo responses, which is not, I think you can logic out why those might be. But you can see here in our meta-analysis, about 33 or 37% relative improvement in attaining a meaningful improvement in pain. And what that amounts to is about 39% of patients on a cannabinoid will attain a meaningful improvement in pain versus about 30% in placebo. And click through, Sam. Now, what might this look like in a graph? This is what that looks like on a table. So you can see if you're doing this as an icon array, the number of patients who actually feel better due to the cannabinoid is in green. Those who feel better because of placebo is in yellow, and those who are in red don't get an improvement. This is available from the guideline itself, and it's also available on the pain calculator. So you just Google pain calculator, and it will take you there. One of the key things about cannabinoids is whether they work or not, obviously, is important, but also what are the adverse events? And that's where cannabinoids struggle. They struggle because adverse events are frequently high. Things like sedation and some of the other stuff like speech disorders, dizziness, all sorts of things are higher. So it's just important to remember that these are not, they might be natural if the patient is using inhaled cannabis, but it does, especially for novice users, it causes quite a few adverse events. The next piece is, you've probably heard this, well, if we use CBD or THC, it's better. Surprisingly, there's very little research on that has actually compared the combination of THC, CBD to THC or CBD alone. this is one of the clinical trials, and you'll scratch your head maybe a bit because this is one of the best ones we have, and it was 3 hours long. So you might say to yourself, but we're treating chronic pain here. This is common in many, especially the cannabinoid research. It's not uncommon for the studies we've already just looked at to be 5 hours. This one was 3, but it was much more carefully done than a lot of the other ones. Anyhow, what you can see is that CBD had the lowest pain change, both in a NRS, which is basically the same as a visual analog score. It had the lowest reduction in pain with CBD alone, and CBD alone was the least likely to reach a 30% improvement in pain. And why were their placebo effects so high at 55%? It's because the study was 3 hours. If the study had gone on for 12 weeks or something, you would see a much lower placebo response rate. But just important to recognize that the combination seems to be better in the clinical trial data that we have so far. Just it's an important point to take. So if we're going to summarize up, at best, medical cannabinoids reduce pain by about 30% or more for 1 in 11 patients. And what that translates to in real numbers is that 39% will feel improved versus 30% with placebo. It's important to know that the research is highly biased in the ways that I have mentioned to you already, plus more. And so when we looked at longer studies or studies that were larger, which are surrogates of quality, that the effect of cannabinoids disappears. So just important to remember to keep in context. We're not saying that they absolutely don't work because the high quality ones suggest they might not, but it is a concern for us to remember that they're maybe not as effective as other agents. They certainly have lots of harm. So we just need to reserve them as kind of third line. Okay, Sam, thanks.
Thanks. All right, we're back to our board. Maybe we'll pick one more that came out on top from our survey, and then we can look into the chat to see what came out. The next one that was popular was gabapentin and pregabalin for neuropathic pain. So this is one that I covered. And so we did some work around neuropathic pain, and that work is still emerging. So I'm going to present to you a little bit of work that was done a couple of years ago by the peer team around gabapentin. So in this work, they did a systematic review of 18 randomized trials of over 4,200 patients, and those trials lasted from 4 to 12 weeks. And there was a mixed number of conditions. So we saw mostly post-herpetic neuralgia and diabetic neuropathy. There was also a couple of studies on mixed neuropathic pain and nerve injury. And the doses of gabapentin they used ranged from 600 to 3,600 milligrams per day. So looking at that outcome that Joey mentioned, so meaningful pain improvement, the systematic review showed that 47% of patients on gabapentin got meaningful pain improvement compared to 28% who were on placebo, and that translates into a number needed to treat of 6. So we do have a neuropathic pain systematic review coming out, and it seems like our results are also very similar, associated with a number needed to treat of 6. The adverse events that we're seeing were things that we see commonly in practice. So patients will complain of dizziness and ataxia, and those were among the most common. Patients also will complain of somnolence, so we saw that with a number needed to harm of 12, and withdrawal due to adverse effects was 11% in the gabapentin group and 8% in the placebo group with a number needed to harm of 31. All right, so for pregabalin, this comes from a Cochrane review, and so it was one systematic review of 45 randomized trials, approximately 11,000 patients, and these studies range from 2 to 16 weeks, again, a mixed bag of conditions, and the results you'll see here are for pregabalin 150 milligrams twice a day. And for post-herpetic neuralgia, 50% of patients on pregabalin got a meaningful pain improvement when compared to 25% on placebo, and that was associated with a number needed to treat of 4. And for diabetic neuropathy, they also similarly benefited, 47% on pregabalin versus 42% on placebo with a number needed to treat of 22. Higher doses tends to be a dose response here. So 150 milligrams per day or 75 milligrams BID doesn't seem to work except for maybe in post-herpetic neuralgia. But for our diabetic neuropathy, you may need to get to that 150 BID. And the adverse effects profile was also similar, dizziness and somnolence being among the most common. And withdrawal due to adverse effects were seen in 14% in the pregabalin group and 5% in the placebo group. All right. So the bottom line for gabapentin and pregabalin, both gabapentin and pregabalin can moderately improve pain in about 1 in 4 to 6 patients. Both have adverse effects, and the incidence of adverse effects likely depends on the dose that they use. But there's no head-to-head randomized trial evidence comparing the efficacy or tolerability between the 2 medications. So if somebody says one is better than the other, we actually don't quite know that as yet.
So Sam, we have one question regarding this, and that's questions around dosing. And I think you had the dosing there for gabapentin, but just clarify that, and then I'll ask the next questions regarding dosing.
So dosing, I mean, we usually start at 300, or we would recommend starting at 300 QHS. And if your patient is elderly, you can even start as low as 100 QHS, 100 milligrams QHS, and titrate from there. So that would be your starting dose, and you can increase by every 1 to 2 weeks, I think. However, and when we were in school, we always were taught, 2,400 milligrams, 3,600 milligrams per day were the target doses, which are big doses. But actually, when I joined Pure and I did some reading, we realized that actually you don't need to get to those target doses before doing some reevaluation. So if you get to 900 milligrams per day and your patient is not getting a somewhat of a response, if they're not having any response, then it's probably time to jump ship, because it's not going to work if you continue to push the dose. So 900 milligrams is kind of per day is the dose where we would say, if it's really not working for you, let's try to find something different.
This reminds me of the clinical trials. There's clinical trials of gabapentin, of course, that have been used for hot flashes, and they were moderately effective. And then there was one trial that said this is as effective or close to as effective as estrogen. And when you looked at the dose, it was, I think that was it, 900 TID or something like that. And I had this idea that it's probably not working for hot flashes as much as they're so snowed they don't know they're having hot flashes. Like it's at those doses, it's obviously very hard. And interestingly, so Sam gave the range that I would normally do, but we have seen in a recent clinical trial, this was for alcohol use disorder, a much quicker titration. So it was 300 at bed. The next day it was 300 at bed and 300 at breakfast. Then the next day was 300 breakfast, lunch, and bed. And then the next day was 300 breakfast and lunch, and then 600 at bed. And that was their peak dose was 1,200. So many of the clinical trials don't use those whopping doses, and some titrate much faster, some slower.
Great. All right, we'll go back to our board. Are you seeing anything in the chat that's worth?
Yeah, I think we have a question about SNRIs. We can, I know we have a couple of them, but we can start with SNRIs for OA.
Okay.
Yeah. So this is a question I've kind of sometimes came across, like SNRIs and osteoarthritis. There's actually some guidelines that speak to using SNRIs in osteoarthritis, specifically knee OA. And in our review, what we found were there's 6 RCTs on this topic, which included around 2,000 patients. And that's a typical population you've seen. So, mean age 63. These trials are generally for about 12 to 16 weeks in length. And all these people had knee OA for quite a long duration as well. So this wasn't a new onset of knee osteoarthritis. And what they gave was duloxetine, and the doses range from 60 to 120 once a day, and the titration kind of varied as well. Some trials they kind of titrated 60 for a couple of weeks, and then they bump it up to 120 if they tolerated it. Some were more gradual. They took it from 60 to 120 over 3 to 7 weeks. So you can kind of see it all ranges, but at the end of the day, that's kind of the doses 60 to 120 is where they all fell. In terms of placebo, they're all matching placebo, and these are very well done trials in terms of methods, good randomization, good concealment. And what did they find? So they found that in terms of a meaningful pain relief, there's 64% of patients on duloxetine reach this pain relief as meaningful pain relief versus 43% with placebo. And that kind of gives you a number needed to treat of 5, which is pretty outstanding, especially for osteoarthritis, a condition we probably see a ton of. and this kind of benefit is pretty great. Adverse events is something, of course, we all wonder about, and there were adverse events with duloxetine. So you can kind of see here overall about 1 in 2 patients would get an adverse event, some sort of adverse event versus placebo at 37%. And you can kind of see here who discontinued the medication because of adverse events. 12% in duloxetine versus about 6% with placebo. So do you see more patients stopping the medication because of these adverse events? But GI adverse events were also pretty high. About 36% of patients had GI adverse events. So that would include things like nausea, vomiting, things you probably heard of when you prescribe duloxetine. In the next slide, Sam. The key bit here is duloxetine, because it's this newer agent, and there's a lot of industry sponsorship prior to it becoming genericized recently. All of them are industry sponsored. And all of them, if you looked at the quality assessments, we did an objective quality assessment for each trial. All of them came out like stellar. They had very rarely did they have any issues with them. And it kind of brings the question, like is this too good to be true? But it's a hard question to answer because they proved it over and over again over multiple trials. So it's sometimes it's hard to ignore this. But I think the key bit, and it's those people who be more cost conscious, is does venlafaxine works just as well? Unfortunately, there weren't any studies looking at this topic because it's likely because of that sponsorship or that funding. Venlafaxine has been genericized for so long. There's probably no money backing that medication up. So there's just this huge focus on duloxetine. If it's someone who's very cost conscious, I would say you could probably just start with venlafaxine, see how it works, and give it a shot, because mechanistically wise, they aren't really different. If anything, it's the cost is the big barrier sometimes. And bottom line here, duloxetine does seem to work in osteoarthritis, and there are side effects, and you'll get people discontinuing because of these adverse events.
Great, thanks, Joey.
Okay, a couple other questions, Sam, just really quick. One was about renal dosing for gabapentin. And I suspect it's similar with the idea when you were saying in the elderly, but I personally go on UpToDate and look up the actual drug monograph and see what the recommendations are. But do you have anything for that?
For gabapentin, when patients have renal impairment, it's usually an extension of the dosing interval. So instead of doing TID dosing, it would go to BID dosing or once daily dosing. And there would be caps as well on the absolute dose. And I would also go to Lexicom or UpToDate or whatever. But general principles is that we tend to extend the dosing interval, and there will be a range or a cap on the absolute dose.
That's an interesting, and if James was here, he would fully support that, right? About, I've heard him talking the same thing. It's not just the dose, but also the dosing interval, right? Giving it a chance to get excreted. And the last question was, do you recall the doses used for Lyrica or pregabalin?
Yeah, most of the data that was on that slide was around 150 BID. So you wouldn't start a patient on that necessarily. You might start them at 75 BID, or even I've seen like 50 TID. Like there's some choices, I think. But if you're getting a patient to 150 BID and they're not responding, that's probably, you can go higher, but I think that's the dose around which we saw most of the benefit. So if you're not seeing anything at that dose, I would say maybe it's time to reconsider. If you're seeing a partial response, you could consider increasing the dose, but it's around 150 BID.
Great. One other thing is someone wrote in about heat, ice, and other interventions for chronic pain in general. And we won't be covering that today, but just a word to the wise, our member interest group is teaming up with our group at the college, and we're working on creating a series that will address this on non-pharmacological interventions for chronic pain, things like mindfulness and all of that stuff. So that will be covered. Joy, do you remember, did we look at heat and ice at all? I can't recall that.
No, we didn't.
I don't think so. So sorry about that. It might be helpful for pain. I know it doesn't do a lot for swelling, but it might be helpful for pain. Sam, one of the next ones, there's a couple that we can come back to, but NSAIDS for OA was one of the ones selected, and I think we'll do oral first.
Okay. That's you, Joe.
All right, that's me. So, this is this came from our previous systematic review on osteoarthritis. Came out last year, or early this year, I believe. So we looked at, how well do NSAIDs, oral specifically, work for osteoarthritis? Something we commonly use. And what we found was there's a ton of data out there on knee and hip OA mainly. Again, duration of the trials being 6 to 12 weeks there, but a majority of this evidence actually were the COX-2 inhibitors. So celecoxib, etorcoxib, which is not on the market right anymore. And actually very little was on the ones we use a lot of, naproxen and ibuprofen. And again, it's probably because of this whole, there's a lot of money backing those COX-2 inhibitors during that time, and likely so it pushed all this research during that period. But what we did find in general was there was a good benefit to NSAID in osteoarthritis, just as good as a SNRI, with 57% reaching that clinical meaningful change. And I think some of the big question was, do COX-2 inhibitors work better than traditional? Do they work less? And what we found in our evidence is they work relatively the same. A 7 versus a 6 in terms of number need to treat is within the range of variability. So I'd say they're identical in terms of effectiveness. And this actually, the effect on pain stayed consistent. So what we did was we took all the studies and we kind of broke them up, and we asked the question, maybe does using it more at the beginning of treatment, does it work better than towards the later parts in treatment? So during the first month of using an NSAID, does that work better than using an NSAID 3 months later? And the effect on pain was pretty consistent throughout the time frames we looked at. So NSAIDs consistently showed a pain reduction. And then in terms of adverse events, because of course this comes up a lot, celecoxib specifically, in terms of withdrawal due to adverse events, there wasn't that much of a difference versus placebo. We found here bleeds wasn't an issue, but the key thing is, if you're a study creator, you're creating this RCT, you're not going to enroll patients who are at high risk of a bleed or high risk of a cardiovascular event. So I think a lot of the questions I hear from clinicians when we talk about this is, what about the patient I have who has a creatinine clearance of less than 30? Should I use NSAIDs? And it's one of those, I think your assessment is probably something you should rely on, because the study excluded all those types of patients. And likely we've seen harm data, like those patients are at high risk of adverse events. And of course they didn't include those. So don't want to have this list of numbers here for adverse events be representative. It's definitely not. But if anything, traditional NSAIDs, even though it looks like they had more adverse events here, they actually were just better at reporting them more consistently. And at the end of the day, COX-2 and traditional NSAIDs were fairly similar in effectiveness. And I think it's okay to start with traditional NSAID or COX-2. Some patients love their celecoxib. Definitely hear that. So either or, whatever is with the patient's preference, and it's a good option for OA. Be careful of adverse events. Definitely use your clinical judgment on, at what point maybe you shouldn't use or take away an NSAID based on someone's creatinine clearance and all the other factors you're looking at. But that's kind of what we found.
Awesome. Joey, there's a quick question about going back a step, and that's duloxetine for other forms of OA. Because as you know, most of the studies were on knee OA, but people with hands, and this seems to me to be one, although not studied, I think I might take the leap of faith. We call this in grading, we call this indirect evidence, but if they had bad OA of their hands or hips, I would probably be okay using duloxetine in those patients as well. How do you feel about that?
Yeah, no, I think that's definitely a good strategy. Even though there's no RCT data necessarily, I think it's an option, because you're kind of faced with the clinicians on the webinar here. they probably tried all the typical treatments, right? And you're at this point now, what else can we try? And I don't think it's harmful to try an SNRI for hand OA, even though we don't have the evidence.
Yeah, it's not as good. And then one of the other questions was head-to-head comparisons in the NSAID world. And I know this one's about NSAIDs and acetaminophen, but we also know that there were head-to-head comparisons between COX-2s and traditional NSAIDs. And in those cases, they ended up with the same results, like the two were equally effective at reducing pain. But do you recall the NSAIDs and acetaminophen?
Yeah, unfortunately, nothing strong came up with. Actually, I don't think anything at all really came up with head-to-heads versus NSAIDs and acetaminophen. But what we did find was that acetaminophen in chronic OA doesn't work actually at all. And if we go to the slide, we can kind of speak to that. But NSAIDs came out ahead if we looked at them separately, but there was no head-to-head.
Well, there was, I remember one small trial where they did compare them directly, and the NSAIDs were better than acetaminophen. Like it stuck to the pattern. It was a 3-arm trial with placebo, and it stuck to the pattern that you'd predict. NSAIDs worked okay, and acetaminophen really didn't have much effect. But so one of the other things was, one of the next ones was exercise.
Okay, exercise for, let's do low back pain or osteoarthritis, did they say? I think it was OA from what I saw.
I think so.
Okay, so this is you, Mike.
Oh, it's me. Hey. Awesome. This is going to happen. Yeah, I forget all the time. So it's age. It's age related. Our next talk will be on dementia. So 11 RCTs with 13,000 patients. And again, it's always knee and hip really that are studied. And shorter durations because it's harder to go longer a lot of the time for these. Although we have, I think, some in the back pain one that went much longer. And they're often, one of the things to remember here, because in simplicity, I'd love to just tell my patients, give them an exercise script or tell them to go home and do more activity of their kind of choosing. But most of these were led exercise programs. So going in and doing exercise with physiotherapy leading that exercise program. Next slide. So what about what's the improvement? So the thing is that you have to keep in context here that exercise is consistently better for OA and for actually tons of things. But one of the challenges is that activity trials often have an inadequate placebo arm. So the placebo arm is often just, you didn't, when they're randomized, you didn't get in the actual exercise arm, but here's a pamphlet or something like that, or you're put on a wait list or things like that. They just say you're waiting to get your intervention, and they kind of hold them off for the 12 weeks or 10 weeks. So that will make the placebo effect smaller. And when the placebo effect gets smaller, that means that the drug effect looks very much more dramatic. So exercise, I still think it works, and I think it works well, but it's dramatically better than placebo. You can see there the relative risk is 2.36. As a reminder, the cannabinoids was 1.37. So this is over double, and the cannabinoid was only about 30% better. That's 47% versus 21%. So again, clearly more than double. If you look at smaller trials, it maybe showed a bit better effect, which is what you would expect as well. Adverse events, there's no differences. We said before on other things that we've done, like the podcast, etc., that there are risks of exercise. You can, as you're escalating, you can roll your ankle, etc., but they don't come out in high enough numbers to be picked up in a randomized control trial. Next slide. So this is what it looks like when you convert it using the 2.36 to an icon array, which is the way you're supposed to do this in evidence-based medicine, but it looks darn dramatic. So we really debated in the peer group, do we do this and say that it works this well with only 6% of people not benefiting? Well, maybe it would be close to that if people actually followed our advice, but as we know, they don't actually follow our advice. And secondly, we thought, well, there are lots of other advantages to being active. It improves sleep, it reduces your risk of depression, all sorts of things. So if anything, we're going to over promote, it would be exercise. And I think this might overstate the benefits of it, but it's still the most effective treatment we do have for osteoarthritis. So just a reminder of that, and to encourage our patients to try and get in, particularly something that activity is led.
All right, great. I see your request for PRP for OA on the chat, and also in our survey, we also had a request for exercise for low back pain. So do you want to start with PRP first, Joey, and then we'll do exercise? Yeah. Sorry, let me find it. Okay.
Oh, no worries. Yeah, so in terms of PRP for osteoarthritis, so just like kind of a reminder of PRP and osteoarthritis, PRP injections are, you take the patient's blood, you put into a centrifuge, spin it, take the plasma, and then inject it into that area where they have pain. And the idea is that it's supposed to help heal the area faster and reduce pain in that area. And it's a big treatment. It's being recommended a lot at sports medicine clinics. What's the evidence say? So we found 5 RCTs looking at PRP versus saline injections for knee OA. And the first RCT looked at patients with mostly early OA. There's some idea that if you target things early enough, it's going to work better for them long term. And what they found was that PRP 3 injections, so they were given 3 injections, and they in one arm, another arm just a single injection, and the other arm saline. And what they found is the PRP arms, raise this quality of life more so than saline. And I was kind of questioning what this scale meant. So this EQ-VAS is a 100-point scale, and it kind of asks you, how do you feel your health is overall out of 100 points? So fairly subjective. And they found that the people who are enrolling they felt 50 points out of 100 in terms of their overall health. And it kind of raised them from 50 to 70 or 60 in PRP versus not changing in the baseline. But when we actually look at, what's a good number to be at, and when you look at the mean EQ-VAS for Canada, it's actually 80 points. So it kind of shows we're not even reaching that average in terms of people's feeling of their overall health. And it kind of makes me question, is this a clinically meaningful change? So we kept on looking, what else is there? So another RCT looked at 3 injections, PRP versus saline. In terms of pain now, so more specifically, it did reduce pain from about 10 points to 2 points in PRP versus not much of a change, 9 points in saline. So, okay, so people are building a case. PRP seems to work well. What about the other RCTs we found? A couple other RCTs, to kind of just summarize this really quickly, all these RCTs found PRP worked in bilateral OA and OA in these 2 trials here with these weekly injections. So there's actually a lot of RCT evidence that found PRP works in terms of reducing pain. And I suspect a lot of this evidence is why there's been a lot of hype, a lot of support for this. So in terms of adverse events, it seems pretty good as well. One study reporting dizziness, nausea, pain, stiffness, but oh no, it's okay. But actually, not much adverse events reported there. So it looks stellar at this point. Again, to me, too good to be true. So we actually had to keep digging, and I had to get to the point where I was looking at each author to Google them. Pretty much investigate them, creep them pretty much. And we found actually out that all these authors are connected to a sports medicine clinic, number one. And actually a majority of them, they're known for their PRP injections. So, you have these people who are known for their PRP injections, who support them wholeheartedly, and they're the ones designing the study, running them. And they're only running them at their own site. It's not 10 clinics running this trial. So it's definitely, I mean, if you think about it, patients coming to this clinic, what are they expecting? They're expecting some sort of PRP injection, and then you're telling them you're enrolling into this trial. So there's a lot of bias in who's coming into these trials, which can definitely differ the results. And in terms of the bottom line, I think the key thing is, even though the evidence does suggest PRP is better than saline right now, you definitely need more evidence, I think, to really have a concrete answer on this. I wouldn't necessarily just leave it to these 5 RCTs. Price is a huge barrier. We called a sports medicine clinic, and one injection was $450 here in Alberta. And if they need, 3 of them, that's going to be a huge cost. And the other question is, how long do these last? How often are you going to need 3 weekly injections or 3 injections of PRP? All these questions we don't know the answer to, and yet we have this big push. So I'd be fairly hesitant on just this data, even though the data looks good. There's still a lot of things you want to know about, especially if you're gonna, get these patients to pay this cost.
Great, thanks, Joey. It is really expensive. All right.
For sure. Exercise for low back pain.
All right. So exercise for low back pain is me. This was from our systematic review on low back pain that's just about to come out soon. And what we found were 18 randomized trials of over 2,500 patients. And these studies range from 6 to 52 weeks. And so what we found was that 50% of patients who were randomized to the exercise group got a meaningful pain response versus 35% in the control group. And that leads to a number needed to treat of 7. In terms of some of our quality indicators, what we found is that you have to be exercising for more than just 4 weeks. So studies that were longer than 4 weeks were associated with benefit. For example, if they did if the trial lasted from 4 to 12 weeks, that was a number needed to treat of 21. What we also saw was that they measured the benefit after the intervention was complete, so after the exercise regimen was done. And with exercise, there was a persistent benefit. So 53% in the exercise group got a meaningful pain improvement versus 37% in the control group when it was 12 to 48 weeks beyond the intervention. So there's lasting benefits here is what we're seeing. In terms of adverse effects are reported in the randomized trials. So sometimes they talk about increased back pain or joint pain, but actually in the randomized trials, none of these came out to be statistically different from the control group. And withdrawal due to adverse effects was not reported in any of our trials. So what we're seeing is that exercise reduces low back pain when continued over 4 weeks, and it also has a low risk of adverse effects. The type of exercise, I'm just going to throw this in there, probably doesn't matter too much. The type of exercise that we saw in these trials were largely physiotherapy-guided exercises. That formed the bulk of the trials. But we also saw things like Tai Chi and yoga, Nordic walking, so quite a variety of different things that patients could do. And through conversations with peer, I think we've often talked about if you can find an exercise or your patient can find an exercise that they like to do and they can stick with it, that's probably good enough. That's probably what they should go with. So walking and running, those have been studied. There's talk about motor control exercises, and some studies suggest that they may be a little bit better than other exercises. So that involves strengthening and stabilizing the core muscles. But if you look at whether it really is advantageous over others, it's kind of mixed results. So Pilates might also be an exercise that achieves the same kind of motor control type exercise. So those are examples of things that your patient can do. All right.
Sam, that reminds me of when I was looking at this data a couple of years ago, maybe more now, but one of the things I found interesting is another outcome was the recurrence of low back pain, and that those who are staying active have a number needed to treat. It's either 10 or less to prevent recurrence of back pain. So not only is it treating the chronic nature, but the recurrent chronic nature of it. So, it really is, again, it's kind of like we talked about with the exercise or activity in OA. It really is the best treatment for these interventions. It's just hard to convince patients.
Yeah, hard to stick with, but
Joy, there was a quick question about how long the PRP studies were on average.
Yeah, so the trials I summarized there, 6 to 12 months were the duration, or when they measured that pain outcome at the end there. So there were relatively longer trials, and again, we don't have any data beyond that, so hard to know how long they last beyond that point. And I think something I kind of forgot to mention as well. You're going to probably hear a lot of patients or remember a lot of patients saying PRP works, and it's that you kind of have to remember there's that idea that even if you injected that patient with saline or PRP, around 30 to 40% are going to have a response, regardless if it's actual PRP or whether it's the saline component, and you're not going to know which one it is, because just injecting something is going to achieve this pain relief in some patients. And there's this thing, we're all susceptible to it, this idea of confirmation bias, right? You have a patient in your mind that you've tried probably 5, 6 different things for their way, and then you finally send them to the sports med clinic, and this one person, it works miracles for them. You're going to remember that patient, and it's going to stick with you for a very long time, versus maybe the 5 who have reached that point, went to the sports med. They're like, it didn't really work. Let's try something else. And the one that works, it'll stick with your mind, and you're gonna keep thinking about it as you see patients in the situation over and over again. And it's really hard to separate that. We forget the numbers that things don't work. This is the nature of us. So try to keep it in mind, and of course, as more evidence comes through, we'll definitely hopefully update all this information and keep everyone up to speed.
Great. And Joey, there was a quick question. Oh, sorry, that's you just answered that. Sorry about that. The other thing that I wanted to comment on was Eileen wrote an excellent comment in the chat window, which was it was about activity. And when they ask me what I suggest as the best, and I say the one that they will do and works for them with no increase in pain is the best for them. So that is kind of classic family physician advice. It does sound like absolute common sense, but common sense is a superpower. It's not that common. So excellent comment in the chat window. I think what the next one we're going to do is the steroids for low back pain.
Yep.
Yeah. Awesome. So this one is me again. And it does come up quite a bit because really this is one of those ones that's higher level. We're often sending patients for these. Lots of variation in how they were done. So they were done sometimes with multiple injections. Sometimes it required patients, whether they got the injection depended on their pain status and the follow-up injections rather, and so on. So tricky designs for a couple of these studies and hard to mesh into one, but there is good news about it. And so this is 10 RCTs with over 1,000 patients. Sam, just click through. And you can see here that the difference between the two interventions was 44% felt better with corticosteroid injections versus 43% with placebo. This is basically the same. And it wasn't statistically different, of course, or anything like that. Even if you could prove that was statistically different, if we got 1 million people enrolled, it wouldn't be clinically different to get one more person out of 100 better. And no matter which way you looked at this, the different quality of studies, so you looked at larger studies, ones that went longer, ones that had no industry funding, those with a low risk of bias or a lower risk of bias, it didn't really matter. The effect was just about zero. So it's not that it's not reaching statistical significance, but maybe beneficial. It's actually that it's just not working. And withdrawals for adverse events weren't reported. So the bottom line here, just click the bottom line, Sam.
Oh, sorry.
Yeah, is that they really don't work. Now, if you're like me and you've had patients who have had these injections through other mechanisms, or they've requested them and you acquiesce to send them, then you'll know that about 40% of them will return and say, I felt better. And that's what the clinical trials show, they will. But it's not because of the drug. So 4 out of 10 will feel like they got an improvement, but 4 out of 10 would have felt the same if we had injected placebo. And so this is the icon array. It's kind of a sad icon array because there's not a drug effect in there. The effect of the intervention is just basically all placebo. And it was kind of like Joey said, you can't sort out, even with normal interventions and patients say they're better, you don't really know whether it's the placebo effect or the actual drug. But this is one where you can say, okay, that was almost certainly the placebo effect. Okay.
Great. We probably have time for 1 or 2 more.
There was also a question, Sam, you can go ahead and pick the next one, but there was also a question, Joey, about, I think it's one of the local anesthetics, I think lidocaine or something, and we had looked at that for one of the pain systematic reviews. Do you recall which one that was? And I don't think we found a clinical trial that looked at responders, but you can correct me.
Yeah, we did look at lidocaine for neuropathic pain. That comes up a lot. So we looked at, we tried to look for an RCT with responders for lidocaine. We couldn't find any. There may be one on a pain scale or somewhat, but we didn't look at that specific outcome, unfortunately.
Right. And there's a question here about spinal stenosis, and you can't actually tease that out. And I don't know of, we'd have to look very specifically for randomized control trials that used corticosteroid injections for that very specific cause, and they would have to focus on them in the clinical trial. So it'd be unlikely, I suspect, to get a lot of those. And then there was a question about getting people active and how do we discern whether it's just a little bit of a flare in pain because of their activity. And like you, I do tell them if it's only minor that they can continue doing it. But if the pain persists or anything like that, like for those of us who are getting a bit older and we return to a certain level of activity, we often get aches and pains. But we know we have to work through those. So some patients are very intolerant of that, and so they need to be encouraged. But obviously, if it's pain that persists or worsens, then that's not the right intervention, the right activity intervention for them. Okay, Sam, sorry, over to you again.
Okay, our survey showed that our audience want to hear about steroids for OA. And it should open. Okay, This is you, Mike.
This is me. Yeah, so there was, as you know, there was a large clinical trial and a couple of clinical trials, I think now, but one in specifics where they tried to show, or that what the press picked up and what was promulgated was that corticosteroids didn't work for intra-articular injections in OA, particularly the knee. And that was really unfortunate because the trial was designed in such a way, if anyone knew the data, they would design a trial to find that. So I'm going to come back to that at the end and describe that a bit more, why it found no benefit. So these are, you can see the majority here are methylprednisolone and triamcinolone, and they're compared to saline. And injections, actually, any injection works well as a placebo. People love the idea of getting stuck with needles, just like when you burn them for warts, they report far more pain than other treatments, but they like it better. And the same is true of steroid or of injections. They're uncomfortable and they make them nervous, but they actually feel like something's happening. Next slide. There we go. And you can see corticosteroids versus placebo for a meaningful response was almost 20% better. And why was it 20% better? It was because time matters in this case. So once you get beyond 12 weeks or 3 months, these things aren't working. We used to say they work to 3 months, but they barely work once they're beyond about 4 to 6 weeks. The big peak in time for them to work is kind of that first 1 to 2 weeks when they really have a big effect. And then it diminishes over time. And by 3 months, I can't think of a clinical trial that really found a benefit at 3 months. So their harms are barely mentioned in these clinical trials, and many of them are older, and there's often no difference between steroids and placebo injections. We did go looking for possible risk of joint infections. I knew that used to worry me, and I told patients it was between kind of 100 and 1 in 100 and 1 in 1,000, and I was wrong by over a factor of at least 10. So it's the risk of infection is probably at most 1 in 14,000 from a joint injection. So just to really reassure us that they're going to get a pretty meaningful pain relief for a lot of patients with an injection. You can see not all, and many of you are in the same boat as me. You've injected knees that have worked like dynamite, and then other ones that you really get no effect. And in the past, I used to blame my technique, and that may still be some of the problem, but also it doesn't work in everybody, because these are often radiologic guided injections, and they're still not working for all patients. So this is what it looks like when you look at it from an icon array. You can see that with injections, about 70% of people will feel better with a corticosteroid injection, but about 40% of that is actually the placebo effect, and that's the early on pain relief. Research suggests that they can get injected about 4 times a year, and the peak is again between that 1 and 2 weeks, and then starts to taper off. So these guys who did this clinical trial that got all the press, they actually designed to look at pain response only at 3 months. They did not look at pain response anytime earlier. So the only time that patients could report pain benefit was at 3 months, and of course it wasn't any better at that time. Then when we dug in and found out, what was behind this, it was actually Tina Koronic. Tina found that the person was actually had a patent to develop a replacement for corticosteroid injections. So to me, that's a really significant bias in designing a trial that was basically designed entirely to show that it didn't work. So it's very, very interesting. Anyway, back to you, Sam.
Oh, you're muted, Sam.
I think we burned our time anyway, Sam. Or I burned our time for us.
Sorry, the school bell rang in my yard. All right, so I think we're at the top of the hour. So let me just turn to our slide. So if you need to claim Mainpro Plus credits, there's a survey in the chat, so please feel free to complete that survey by the end of day Friday. We have several practical talks coming up that I hope you can join us for. So they're all Tuesday at 12 noon Eastern time. December 15th, join us with Dr. Barb Farrell and her team talking about deprescribing. January 19th, we're bringing in the new year with a talk about diabetes management with Dr. Mike Allen and Dr. Tina Koronic. And on February 23rd, we're welcoming Dr. Simon Moore and Dr. Christine Richardson to talk about eye disorders that are commonly seen in primary care. So hope you can join us for that. And that's all for us. So thanks for joining us and have a great day.
Thank you. Bye.
Thank you.